It's my pleasure to introduce this session speakers. Who's joining us is Mr. Stephen Bevan from the United Kingdom. That's several time zones ahead. He is head of the Human Resources and Research Development at the Institute for Employment Studies. Please join me in welcoming Mr. Bevan.
Excellent. So thank you very much indeed. So good afternoon. It's just gone 5 p.m. here in the UK. And before I start, I'd like to express my gratitude to the National Academy and to the Workshop Planning Committee for the invitation to address you today. I speak at quite a few events and congresses on obesity here in Europe, and it can be hard to get a platform to address issues around employment. So I'm especially grateful for this opportunity. The Institute for Employment Studies was founded in 1969 as an independent, not-for-profit centre for applied research on labour market trends and human resource management. And my background is in organisational psychology, and I lead our work on the health of the working age population with a special interest in chronic illness, mental health and musculoskeletal conditions. I'm also a collaborator at the Centre for Musculoskeletal Health and Work, which is based at the Life Course Epidemiology Unit at Southampton University. And I and my colleagues have been conducting research on obesity, stigma and discrimination in employment for the last couple of years. We've got a new programme of work called the Purpose Programme, which is funded by Novo Nordisk, but over which we at IES retain full editorial control. And the programme is aiming to extend the evidence base on obesity stigma at work in the hope that both the wider labour market and workplaces can become more inclusive, productive, by adopting more enlightened practices to help, and also to explore how it might be possible to mainstream the notion that work, especially good quality work, should be regarded as a health outcome for all. Today, I'm going to be focusing on just 2 or 3 subtopics. It's a very wide topic, as you can imagine, but also to mainly highlight what I think the evidence base is telling us, but also what more needs to be done to erode obesity stigma and discrimination at work. So the themes I'll be picking up on are some general background points about the prevalence of obesity stigma and discrimination in the labour market. I want to focus on 2 specific things: the obesity wage penalty that seems to exist very pervasively, particularly for women. I want to focus a little bit on how worksite health promotion can inadvertently internalise stigma for people living with obesity. And then finally, a few comments about what employers and healthcare professionals can do to improve outcomes for people living with obesity. Now, we all know it's easy to find commentary, contemporary commentary from newspaper and TV pundits, among whom the absence of any scientific credibility has never been a barrier to their sharing their views, both on the causes and cures of obesity. And most of this commentary focuses on issues like willpower and personal fortitude, and an emphasis on eating less and moving more, so highly individualised advice, in inverted commas. And for this group, it seems that overweight and obesity may be what some people call the last acceptable form of stigma and discrimination. Much of the data I have from our most recent study is based on UK data, but I think many of the principles and indeed a good deal of the research has been conducted in the USA as well. Certainly in the UK, we find that almost 50% of UK employers say that they're less inclined to recruit candidates who live with obesity. People living with obesity have lower starting pay, less hiring success, lower co-worker ratings. They're frequently regarded as having less willpower and resilience, and they're less likely to be regarded as able leaders or to have career potential. And women living with obesity in particular seem less likely to get customer-facing jobs, and they're faring poorly in what's called the aesthetic labour market, where how you look is sometimes more important than what your competencies are. And we've certainly seen in recent years examples of at least one international airline, for example, who are mandated that their cabin crew should lose weight before they're allowed to fly, and that's not based on any health and safety criteria. It's just based on aesthetics, and these things can still go on. which I think is interesting and perhaps remarkable. There's also plenty of evidence that employment discrimination, derogatory comments are commonplace, again, especially for women. We find when we've reviewed the literature on this that women on average are 16 times more likely than men to report weight-related discrimination. 25% of women report experiencing job discrimination because of their weight. 54% report stigma from their co-workers and colleagues. So it's a very common set of experiences, and it's one which rarely goes challenged. It's rarely challenged in workplaces, and it's still regarded as something which is outside the mainstream of normal diversity and inclusion practices and policies. Now, we've conducted an evidence review looking at the literature and the evidence on the extent and causes of weight-based stigma. And we found that there are a few aspects of the employment journey for people living with obesity where there's not an elevated risk of stigma and discrimination. In fact, it's pervasive across all different stages of the employment cycle, recruitment and selection, as I've just mentioned, developing relationships at work and well-being, very strong evidence, of course, of mental health comorbidity with obesity, depression and anxiety most particularly. Issues around progression and promotion, so the way that people's potential for progression is assessed, the access that people get to learning and formal development programs and so on can all be influenced by negative perceptions of people's personality, attributions about personality on the part of managers. Retention rates, and also we've seen quite significant evidence most recently about premature withdrawal from the labour market or movements into unemployment amongst people living with obesity. So pretty much at every stage, there are real challenges about the experiences that people living with obesity have and the extent to which their employment outcomes are affected. As I mentioned, I just want to focus on two particular areas of interest. The first is the obesity wage penalty, and the second is worksite health promotion. Looking at the obesity wage penalty, there was a review which I was an advisor to, in fact, in 2016, conducted by the UK government by Dame Carol Black, that identified a 10% wage gap between people living with obesity and those with average weight. The review didn't look in detail at some of the contributory factors or the causal factors, or indeed what the direction of causality was. But that's something that we've now been able to do in a bit more detail by reviewing some of the evidence. Now, of course, we know that there's, and we've had it mentioned already in this round table, lots of research on the social determinants of health, one of which, of course, is employment, conducted by Professor Sir Michael Marmot and his colleagues at the Institute of Health Equity here in London. And it identifies very strong links between poverty, employment, health inequalities, and obesity. And at the same time, living with obesity is linked to lower wages, lower household income through the life course because of gaps in education, poorer health, and employment discrimination. And actually, Professor Marmot only yesterday wrote in the national newspaper, and I'll quote him directly, "We need to consider the causes of ill health. Smoking, poor diet, and obesity are causes of ill health, but the causes of the causes are the social determinants of health, the conditions in which people are born, grow, live, work, and age." And that's particularly relevant to the earlier discussion around structural racism, as it is to the issue of pervasive weight-based stigma. So our review has been looking at the issue of the wage penalty and its causes and its impact. What the research says is that there's very considerable evidence that the wage penalty affects women far more than men. Indeed, there are some studies that show that there's a wage premium for some men who live with obesity compared with women, where the outcomes are almost overwhelmingly negative. Some studies estimate the gap to be up to 20%, with an average falling between 9 and 13%. This wage penalty is not just in annual earnings. There's really strong evidence of a life course impact, where childhood obesity leading to adulthood also carries with it this earnings disparity. And women living with obesity at 16 have a 34% lower household income at the age of 42. I'm going to talk a little bit more in a second about what some of the causes of this might be. We know from some research that women's earnings peak at a BMI of between 20 and 22 and then decrease as BMI increases. One study found that a 1-point increase in BMI led to a 4% drop in income within 4 years. And mothers living with obesity earn almost 7% less than mothers of average weight. And one study found that single mothers living with obesity face a wage penalty of 7.6% per child. Older women with a BMI over 40 are more likely to have extended periods of sick leave and leave employment early. And even if you control for age and other health factors, stigma and discrimination play a really important explanatory role. And this is data from the Health and Employment After 50 study, which my colleagues at Southampton University have been conducting. The references at the end, but it's a very recent study looking at employment outcomes, particularly for women with high BMI. So why does this wage penalty exist? There seem to be at least 4 explanations. The first is human capital differences. So the idea that women living with obesity have lower educational attainment, have limited work experience, are subject to occupational segregation into lower paid and lower skilled and lower status work. And there's some recent work that found a strong link between obesity and occupational prestige and both health and employment outcomes for women. There's a life course barrier explanation that women living with obesity find it harder to shake off the health and education inequalities of childhood and adolescence, and they risk living in lower income households because they're less likely to marry or cohabit with women of average weight. There's a health differences explanation that women living with obesity have more health conditions and comorbidities that affect their ability to find and retain work. These health conditions lead to reduced functional capacity, increased sickness absence, and an elevated risk of premature withdrawal from the labour market for health reasons. And then finally, there's the stigma and discrimination, or taste-based discrimination, as some people call it, that women living with obesity are subject to systemic discrimination in the jobs market and in workplaces, which means that they're sorted into low-paying jobs for which they may be overqualified, and where opportunities for job and pay progression are constrained, and where negative stereotypes and weight-based stigma are common and normalised. So the conclusion from some of this evidence is that the multiple employment disadvantages already being experienced by women in the labour market living with obesity are being compounded in a very tangible way by a pervasive wage penalty, which for many is established in adolescence and follows them into adulthood and through their careers. So how does this penalty translate into the national picture? And I apologise that these are data based on UK assumptions, but we've done some assessments of what would happen if the wage penalty at different levels was translated at a national level into both individual earnings disparities as well as if you gross it up into a sort of more of a macroeconomic picture. We looked at 4 scenarios, assuming the wage gap for women was 2%, 5%, 9% and 13%, based on average earnings and a prevalence of obesity amongst women in the UK, working age women in the UK of 30%. And you can see that if you total that up, the highest level with a 13% wage gap is nearly £15 billion each year across the whole of the UK economy. Now, aside from the individual and household impact of all this, there are really interesting issues around the waste of human capital resources, potential reduction in tax revenues, reductions in consumption, and of course, potential increase in welfare payments. So this doesn't just have individual ramifications for individual women and their families, but also for the wider economy. Next, I want to talk briefly about workplace health promotion. COVID-19 has emphasised to many businesses that workforce health is actually a business continuity issue. And we need to make sure that once the pandemic subsides, that it remains a high priority for businesses. And so in doing so, we need to ensure that Worksite programmes do not add to obesity stigma. And what we found in our most recent work, which is yet to be published, but will be published next month, is that it's clear that well-intentioned workplace health promotion programmes with a nutrition or an exercise or weight management element might inadvertently reinforce obesity stigma. And that's because these programs can reinforce the belief that overweight and obesity can be resolved through exercise or by eating less and moving more. And these are mainly achievable by greater application on the part of the individual and greater willpower. And of course, that might cause some people living with obesity to internalize the stigma that they already experience in wider society, and also can make them reluctant to participate in workplace programs or fail to access support, weight management advice, or psychosocial help from which they might otherwise benefit. And this is a real concern. I mean, there are lots, as you know, of organizations who have very well-meaning and slightly evangelical approaches to nutrition, healthy eating. Some people, there's a famous occupational physician here in the UK who characterised those as the fruit and Pilates approach to workplace health promotion. That they may have wider benefits, but actually if they're targeted ineffectively, then they can have a damaging impact on reinforcing stigma. There's also research that suggests that encouraging competition or using incentives can produce negative outcomes for some workers living with obesity as well. So, pulling all this together, what should be done by which stakeholders? This isn't just about what employers can do. I think there are a number of different groups that can have an impact on improving and mitigating the more difficult and dangerous factors resulting from stigma and discrimination. I think governments can do more to think about public health and the social determinants of health, particularly public health measures focused on reducing obesity. It's not just about sugar content of food. It is actually thinking about employment as a social determinant of health and trying to undermine and reduce some of those health equity problems. In some countries, and certainly UK is one of these, it's still not been decided to designate obesity as a disease. And if that were to happen, certainly in the UK, it would mean that more resources would be thrown at obesity, that care pathways and commissioning of healthcare and so on will be very much different. And we also think that some governments really need to think about, in terms of equalities legislation, designating obesity as a protected characteristic, which places more of a responsibility and a duty of care on employers to do more to protect people living with obesity as a group who suffer disadvantage. Employers can do more by making sure their HR processes are de-risked in terms of risk of stigma and discrimination, and that obesity should be much more explicit in the way that diversity and inclusion programs and policies are put together and evaluated and measured. And also, as I mentioned before, that their workplace health promotion programs do not reinforce stigma, and that they're done in a way which are inclusive, and also involve individual employees in their design. Healthcare professionals can do more to consider work as a clinical outcome of care, and also need to think about comorbidity, particularly mental health comorbidities, as a barrier to work. And so healthcare professionals taking a biopsychosocial perspective on this, I think, would move the dial considerably in terms of inclusive practices and helping people of working age living with obesity to feel more included in the labour market. The media can do more in terms of promoting people first language, using appropriate images, and also not being so simplistic in their presentation of the obesity problem and reflecting the complexity of obesity causes. Just a final quick word about COVID-19. It's really clear from evidence across developed economies that there's an elevated risk of poor COVID-19 outcomes for people living with obesity. And that's also, in some senses, amplified stigma for some people. And this is something we really need to watch out for. It's also had the effect of exacerbating existing health and social inequalities, and one of which, of course, is obesity. And we need to be very vigilant on this. There's growing evidence that some employers are not managing the return to physical workplaces sensitively. We have a government agency in the UK who recently asked all their employees who've been working at home to send in their waist measurements so they can do a risk assessment of the workplace. What were they thinking of? And then finally, risk assessment is prudent, but they should avoid positioning obesity as a burden. I think it's a really important part of the language problem that we have. So, very quickly, final conclusions. The labour market and workplaces are arenas within which much of the intersectionality of obesity drivers and its consequences is brought to life for many people living with overweight and obesity. It's worth recognising that work is not just an economic act, it's also a profoundly social act too. And almost inevitably, many of the challenges in inequalities of the wider social determinants of health play out in these workplaces. This is just as true for obesity as it is for gender, race, disability, and so on. So the more we uncover evidence of the structural and institutional beliefs and barriers which perpetuate obesity stigma at work, the more inadequate the mantra of the eat less, move more appears. Thank you.